This conference will now be recorded.
Okay, start this. Good morning, everyone. Today we will be discussing about an important topic in your final year, that is acute pancreatitis. It is an essay question as well as a 4 marks question. So kindly follow this class. As you're in 5th semester, we will be not going in detail. Just I will be explaining regarding some crucial things which are very useful for you in final year clinics. Kindly note it's an important essay question as well as a 4 marks question. So anytime you will be seeing this question as a short note or an essay question. So before we are going into the actual pancreatitis, just we'll briefly go through the anatomy of the pancreas as we are very versed with the in your first year. So briefly, I will give an introduction like the anatomy of the pancreas. So this is the outline of the presentation. This includes anatomy of the pancreas, etiology, pathophysiology, clinical approach, that is history and physical examination, differential diagnosis DD, investigations, and assessment of the severity of the pancreatitis, and management and its complications. So coming to the first part of the presentation, that is anatomy of the pancreas. So pancreas it's a retroperitoneal organ. In adults, it is about 15 centimeters long and weighs about 70 to 100 grams, and it consists of 3 parts, that is head, body, and tail. And its relations you already are learned in the first year, that is head, neck, consonant, pros, body, tail, regarding with the relations with these parts. So this is the pictorial representation taken from the your anatomy chaurus, BD chaurus. That is, you can see the posterior relations of the pancreas, inferior vena cava, aorta, splenic vein, left kidney, and the spleen. This is the transverse section of the pancreas. See, here we can see the uncinate process, that is C-shaped loop, the head, neck, body, and the tail, which is close approximate with this superior mesenteric vein and superior mesenteric artery. So this is the you can see here the main pancreatic duct, that is called as bursing, and this accessory duct is called as anterinae. See here, you can see the head, body, and the tail, and the blood supply. See, you can see the ducts. Whereas there is the accessory duct, that's the duct of Sandre, and the main duct. So coming to the arterial supply of the pancreas, which is very, very important. See here we can see the from the aorta rising the celiac trunk, which is the supplies major portion of the pancreas. From the celiac artery, you can see the branches like dorsal pancreatic artery, splenic artery, and the greater pancreatic arteries. And here see is common hepatic artery, gastroduodenal artery, and the transverse pancreatic artery. And superior, here we can see the superior mesenteric artery. So now coming to the actual proper topic, that is the pancreatitis. So why it is important pancreatitis? Because as in previous class I have taken the class regarding the alcoholic liver disease. So most common common is among the chronic abusers, that is alcohol abuse. But next to that, again we can see this pancreatitis is most common among the alcoholics. That too the acute acute pancreatitis and the chronic pancreatitis. So the most common cause of this acute pancreatitis is gallstones. Because of the bile duct obstruction, this is the most common cause of this acute pancreatitis is gallstones. So kindly remember this. You may be confused that regard alcohol may be the most common cause of acute pancreatitis, but not the alcohol. The second most common cause is alcohol, but the first most common cause is gallstones. Whereas in the case of chronic pancreatitis, the alcohol is the most common cause. So kindly note it out. So pancreatitis, among the pancreatitis, that is acute and chronic. Alcohol is the most common cause of acute gallstones are the most common cause of acute pancreatitis, and the alcohol is the most common cause of chronic pancreatitis. So in acute pancreatitis presented with abdominal pain, and it usually associated with the raised pancreatic enzyme levels in the blood or urine as a result of pancreatic inflammation. So coming to the incidence, so about 3% of all cases of abdominal pain are pancreatitis, and hospital admission rate for is about 98, that is roughly about 10% per 1 lakh population annually. So worldwide, 50 per 1 lakh cases annually, and the disease may occur at any stage, any age, with a peak in young men and older women. So that's why it's important. So you can see the incidence. 100 people of abdominal pain cases, the 3% people were pancreatitis cases. So similarly, in 1 lakh population, about 10 people were affected with this pancreatitis. So that the most common in a young man. Why? Because young men, because nowadays because of this vesicles or everything. That's because of this chronic abuse, alcohol abuse in younger women and also in older women. Preferably in young men is most common. So coming to the etiology, there's two, as I mentioned earlier, that is two major causes. That is biliary calculi and acute alcohol abuse. See, you can see the percentage. By this, you can say that the most common cause of acute pancreatitis is gallstones. That is about, it constitutes about 50 to 70%. Whereas alcohol abuse, it is, you can see over there, 25%. So less common than that of gallstones. So the remaining cases may be due to rare causes or maybe idiopathic. So we'll briefly see the possible cause of the acute pancreatitis. So you can see that incidence wise, you can see over here in this slide, the gallstones is the most common, next followed by alcoholism, then post endoscopic cholangiopancreatography, abdominal trauma, following biliary, upper gastrointestinal or cardiothoracic surgery, ampullary tumors, and drugs like corticosteroids, azathioprine, asparagines, valproic acid, thiazides, or estrogens. You can see in the pregnant woman, because of the high increased progesterone levels, because of the decreased motility of the bile duct, this bile stasis will be seen. In such a patient, we can see the jaundice. So similarly, because of this estrogens and drugs like this acute because of this bile duct obstruction, the acute pancreatitis may be also common. So next, the hypercalcemic conditions like hyperparathyroidism, hypercalcemia, and pancreatic divisum, the abnormality of the anomaly of the pancreas, autoimmune pancreatitis, hereditary, that is hereditary pancreatitis, viral infections like mumps, coxsackie virus B, malnutrition, scorpion bite, and some other causes. These are the most probable causes of acute pancreatitis. Why this important slide is because in your theory examination or any practical survival, you have to remember these causes, at least 4 to 5 most common causes, so that you can present the examination. So the firstly, gallstones, alcoholism, abdominal trauma, at least 4 to 5. You have to remember because it's very important theory topic. For theory purpose, this question is very important. It's an essay question as well as a short notes. So how to remember this causes of this pancreatitis? You can make some mnemonic on your note, or if you may also note this mnemonics. So I get smashed is a mnemonic. See, you can see I is for idiopathic, G is for gallstones, E is for ethanol, other is alcohol, T is for trauma, S is for steroids, and M is for mumps as well as malignancy, and A is for autoimmune, scorpion stings, H for hypercalcemia, hypertriglyceridemia, or hyperparathyroidism, or E for ARCP, and T for drugs. See, remember these things because this is very important topic. Acute pancreatitis is very important topic for a UG undergrad. So kindly take a notes or follow the slides after this class. So as you mentioned, that is the common from the etiology wise, the gallstones as well as alcohol. So first coming to the gallstones pancreatitis, transient blockage of common bile duct, that is because of the bile duct obstruction, this bile gets stasis and leads to the pancreatitis, and this as a result of this blockage of the bile duct, this reflux of bile into the pancreatic duct and impairs flow of normal pancreatic juice. So as a result, because of this obstruction to this normal pancreatic juice flow, premature activation of this pancreatic enzymes takes place within the duct system. So as a result, this pancreatitis expresses. So in case of gallstone pancreatitis, the main you have to remember that because of that blockade, this pancreatic juice does not flow normally, or free flow does not occur. As a result, it gets stasis within the ducts. As a result, premature activation of these pancreatic enzymes lead to the damage of the SNR cells. So remember this, gallstone pancreatitis, one of the pathophysiology is like this. In case of alcoholic pancreatitis, in whom it is high risk is in case of long-standing alcohol intake for at least 2 years, or single session of heavy drinking, or consumption of more than 80 grams per day. So alcohol in these people, it's very highly risky because they'll be taking chronic alcohol abuse or binge alcohol drinking for about 2 years, or in a single session of heavy drinking that is more than 80 grams per. So what happens? So what happens if in this case these people consumes a larger amount of alcohol? So what happens? So alcohol has toxic effect. It has a direct toxic effect, or it leads to the increased viscosity of the pancreatic juice, or it leads to autodigestion and impairs the secretion of zymogen granules. So in detail we will see. So what happens? So alcohol has a direct toxic effect. What happens? So alcohol in genetically predisposed individuals, it has a direct toxic effect, and it also leads to the viscosity of nature of the pancreatic juice increases. So as a result of, because of the increased viscosity, there will be a formation of protein plaques and impairment of flow. As I mentioned previously mentioned, see in case of gallstone pancreatitis, these gallstones obstruct the bile ducts. But whereas in this case, see here you can see in alcohol band, because of this increased viscosity nature, this free flow will be decreased. So as a result, because of the decrease in free flow, the pancreatic juice gets stagnant over in the bile ducts, pancreatic ducts, and leading to the formation of platelet flux. So here see, because of this formation of the protein platelet flux, the premature activation of these pancreatic enzymes within the pancreas, leading to the process of autodigestion. As I mentioned earlier, see, because of the stagnant nature of this premature activation, finally it will lead to damage to the SNR cells of the pancreatic cells. This entire process is known as autodigestion. So anything that injures the SNR cell and impairs the secretion of zymogen granules or damages the bile duct epithelium and thus delays enzymatic secretion and can trigger acute pancreatitis. So as I explained earlier, this is self-explainable. So you can see here. So once a cellular injury has been initiated, the inflammatory process can lead to pancreatic edema, hemorrhage, and eventually necrosis. This is the pathology in this pancreatitis. What happens is, initially because of this autodigestion, see the SNR cell damage, because as a result of SNR cell damage, this pancreatic edema takes place, and as a result associated with the hemorrhage and necrosis. These are the three pathological features of acute pancreatitis. As inflammatory mediators are released into the circulation, systemic complications can arise. So what happens in case, because of this inflammatory mediators, there will be a patient may be present with abdominal pain as well as fever, vomiting, nausea sensation, and sometimes patient may, because of this inflammatory mediator, the patient may be land into sepsis as well as septic shock. Suddenly he may develop hypertension. So some of the complications. So we will coming in the coming slides. We will be seeing the complications as well as. So here we can see briefly you can see that causes. Here see we can the duct obstruction, because what is the main cause of duct obstruction? That is polylithiasis, that is gallstones, ampullary obstruction, chronic alcoholism, duct concretions, resulting interstitial edema. As a result of the edema, there will be impaired blood flow, and as a result of impaired or decreased blood flow, there is further leading to the ischemia. As a result of ischemia, the SNR cell injury occurs. So see here, direct SNR cell injury, how it occurs, as I mentioned earlier, because alcohol it has a direct toxic effect on the SNR cells. So see here, some of the causes like alcohol, drugs, trauma, ischemia, and viruses. Because of these release of intracellular proenzymes and lysosomal hydrolysis, this activation of the enzymes takes place, and as a result, again, autodigestion, that is damage to the SNR cell, that's SNR cell injury. So see, defective intracellular transport. So how it happens means, see, metabolic injury or alcohol duct obstruction, see, delivery of proenzymes to the lysosomal compartment, and intracellular activation of, see, all these are main different causes. See, duct obstruction, SNR cell injury, defective intracellular transport, all are further, again, mainly leading to the final is SNR cell injury. Because of this SNR cell injuries, so these enzymes get activated. So this leading to the inflammatory conditions. So leading to the edema, and further because of the premature activation of the enzymes, leading to the proteolysis, and because of fat necrosis, and also the hemorrhage. So these are the 4 pathological lesions in acute pancreatitis. So you have to remember that inflammation, proteolysis, fat necrosis, and hemorrhage. So coming to so this is a theoretical aspect, that is etiology and causes. So how will, if a patient comes to the casualty with an abdominal pain and is complaining of nauseating sensation, and he gives a history of binge alcohol drinking or a chronic alcohol since 2 years. So how will you come to a conclusion that this patient may be affected with acute pancreatitis? So this is you have to carefully listen this regarding the history and physical examination. Why it is important to come to a conclusion that this patient may be landed in the acute pancreatitis, he may having acute pancreatitis or some differential DD. Through this history physical examination, we will know. See, what is the purpose of history taking is because the patient may come to the casualty with a complaint of abdominal pain, severe abdominal pain. So because as I mentioned earlier in the initial slide, out of 100 people presenting with the abdominal pain to the casualty or something or an OPD, 3% people are of acute pancreatitis. That is why it is important to elicit the history, because there are several causes of abdominal pain, not only acute pancreatitis. So there were several causes. So to differentiate from that, initially clinically, because we are not be having any investigations immediately as the patient comes to the casualty. So we have to assess, we have to clinically examine the patient and come to a conclusion that this patient may be having some GRD, or this patient may be having from abdominal pain, or because acute pancreatitis or some other causes, or any lumps in the abdomen. So we have to come to, or it may be acute appendicitis. So we have to come to the diagnosis. So clinical history is very, very important in this patient. So next is because how, so causes. So as I mentioned earlier, because alcohol may be the cause, drugs may be the cause, gallstones may be the cause, or any hereditary pancreatitis or something, so and so. So we have to elicit the proper history, and we have to assess the complications. So what stage maybe the patient may be presenting to the casualty, that whether maybe he may be in any shock, presented with any septic shock condition, or he may be having some local complications, or he may be having any systemic complications. So this assessment is very, very important. So coming to the history taking, there is abdominal pain. So you have any pain, you have to observe the patient, or you have to examine the patient in the following subheading. See, site. In this case of acute pancreatitis, the patient complains of the diffuse pain and upper abdominal pain. Mostly in the most common in diffuse upper abdominal pain, and the onset is sudden, and the character is of boring pain, and it radiates to the back, and associated factor is as like nausea, vomiting, dyspnea, and timing. Pain accelerates in intensity and peaks within 10 to 20 minutes apart. This is very, very, very important side, because these are the characteristic features of acute pancreatitis. So in your any question, you have to write in the clinical features, you have to write all these 5 points, because site, it is diffuse abdominal pain, onset is sudden, character is boring pain, radiates to the back, associated factors like nausea, vomiting, and dyspnea, and the timing is pain aggravates in intensity and peaks within 10 to 20 minutes of onset. Why it is important? Because here see, the site of is diffuse abdominal pain in the upper abdominal region, whereas in the appendicitis pain, you will be seeing the pain in the right iliac fossa. So that is the difference between both. The pains radiates to the back, but in this case of acute pancreatitis, these patients, the pain will be in the diffuse upper abdominal quadrant, this is upper regions, whereas in the appendicitis patient, it will be in the right iliac fossa. So that's why it's important to know the characteristics of the pain in both the cases. So aggravating and relieving factors: aggravated by breathing with increased intensity, chest expansions, and relieved by leaning forward. Whereas the severity coming to the severity, depending on severity, patient may present in shock, as I explained earlier. In this case of pancreatitis, because of this inflammatory mediators that is inflammatory is released into the blood, leading to the, and finally patient may be landing on septic shock, that further leading to the fall of blood pressure and hypoperfusion, and finally patient may land into multi-organ dysfunction, and finally patient may be dead. So coming to the history of underlying causes. So in earlier I have mentioned how to remember the mnemonics. It is a repetition of the slide. So coming to the complications. So as I mentioned, when the patient comes to the casualty, we have to assess the patient, whether this patient is really is in acute pancreatitis condition. So then what, he may be having any local complications as well as systemic complications. So for the further management, we have to assess the patient whether he is in any complication stages or not. So coming to the systemic complications that are common in this acute pancreatitis, the patient may have develop acute respiratory distress syndrome, renal failure. So coming to the cardiovascular system abnormalities like shock and arrhythmias, and metabolic parameters like hypocalcemia, hyperglycemia. Why hyperglycemia? Because hyperglycemia occurs because of the SNR cell damage. Pancreatic cells will be damaged, and the insulin secretion will be decreased. As a result, hyperglycemia occurs. So, and finally, a patient may also develop encephalopathy, that is altered sensorium, and a patient may be hysterexis, or if the cause is hepatic, then there is a hepatic encephalopathy. So these are the conditions. So coming local complications, mostly the patient develops silently, and coming to the most common local complications, that is pancreatic abscess. That is, patient may be, because of the abscess, the patient may present with high grade fever. Another complication, that is pseudocyst formation or pancreatic effusion. That is most common in left-sided pleural effusion. Also, it may develop in these patients. So coming to the physical examination, and you can see that vitals, we will be noting the vitals of the patient, and in that case, we will be seeing that the elevation of body temperature is often present in acute pancreatitis. So coming to the abdominal examination. So this is the, before all this is the inspection inspector findings. Then now coming to the proper examination, that is inspection, you will be seeing the abdominal distension. Because of this hemorrhage or the edema, there will be effusion around the pancreas. So because of that, there will be fullness of the abdomen. On seeing an examination, you will be noting the abdominal distension. And coming to the palpation, we will look for any hepatomegaly present, any tenderness, Cullen sign, great Turner sign, peritoneal signs like rigidity, guarding. Because of the pain, the patient may experience rigidity as well as guarding. So here we can see these are the most. Again, you have to note these two signs, because these are the signs which differentiates it from appendicitis. What is Cullen sign? What happens is, see, around the umbilicus there is a bluish hue. This formation of bluish hue around the umbilicus, it is called as Cullen sign. And what is the great error sign means? It is around the flank region. So you can see this is the left side of the left flank region. You will be see the bluish discoloration around the left flank region. It is called as great Turner sign. Whereas the bluish discoloration around the umbilicus, it is called as Cullen sign. So kind of don't get confused both these signs. These are the characteristics of this acute pancreatitis: Cullen sign or great Turner sign. You have to write both the signs in examination purpose. So coming to the percussion, dullness suggesting ascites and auscultational findings are you will be see the abdomen for hypoact or an absent bowel sounds or an abdominal bruit, and ileus is most common in pancreatitis, and auscultation of lungs. 10 to 20% of patients have pulmonary findings, commonly left-sided findings, that is basal rates, eclectasis, and pleural effusion. Among this, you have to remember this pleural effusion because of this inflammatory condition, or also leakage of the fluid, hemorrhage, and also leakage of fluid. You will be seeing the pleural effusion. That is the most common in left-sided pleural effusion is most common in acute pancreatitis. So kindly note this. This is very important. Pleural effusion. What which side? It is left-sided. That is most common in acute pancreatitis. So coming to the differential diagnosis, investigations, and severity scoring. So first we will see what is the differential DD. As I mentioned earlier, the differential DD may be that around acute appendicitis or any some other cause we will see coming side. See, so in case of mild acute pain or in case of severe acute pain, if it is case of mild acute pain, then the differential DD include that is acute cholecystitis, that is gallbladder inflammation condition, peptic ulcer disease, inferior myocardial infarction, acute appendicitis. See, all these patients were complaints, similarly the complaints of common, that is mild acute pain. So as I mentioned, in the case of this pain is in right iliac fossa, then it will the differential DD in the most towards the acute appendicitis. So in this patient may also present with the right side pain, upper abdominal pain. See, as I told in myocardial ischemia, also the patient may sometimes they may be presenting with abdominal pain, that is low in the upper part abdominal pain, along with the burning sensation in the chest region. And see, another differential is the peptic ulcer disease and acute cholecystitis. All these are differential DD for the mild acute pain. When it comes to a severe acute pain, then fecal peritonitis due to the perforated colon may be the differential DD, and also the ruptured abdominal aortic aneurysm and ruptured ectopic pregnancy and massive bowel infection. So in this ruptured ectopic pregnancy, we can see by Calder census we can make out the rule out this condition, that ruptured ectopic pregnancy. But see, these are the differential. These are the 4 common differential DD in case of patient presenting with the severe acute pain. So coming to the investigations, see, the diagnosis is made on basis of clinical presentation and elevated serum amylase and characteristic images. Generally we will see the elevated serum amylase levels, but this is not specific, because in coming study you will be seeing that this serum amylase level is not specific. This may be elevated in some other conditions also. So coming to the biologically, the serum amylase levels increase 3 times than normal or more than 1000 international units per ml, and it peaks within the first 24 hours after onset of symptoms. So serum lipase has a longer half-life, thus more useful in delayed cases. So at the time of earliest presentation, if the patient presenting casualty around only 1.5 after 2 hours of pain, then we will definitely we have to go for serum amylase initially. So if the values are more than 1000 international units per ml, then it will be, then we can come to conclusion. We may not come to the conclusion. Then initially we may think of acute pancreatitis. So this serum lipase, it's more sensitive and specific for pancreatitis than MLS. That's why I mentioned here. This is not specific because serum lipase level has a longer half-life, thus and more useful in case of delayed cases. In case of delayed cases, we will go for lipase. But immediately if the patient present to the casualty with the pain, then first we will be sending serum amylase. Then only after duration of about 12 hours, after 1 or 24 hours, then we will be going for serum lipase. See here, why I have mentioned the serum amylase is not specific. See, in case of renal failure, liver cirrhosis, peritonitis, GIT inflammation, ruptured ectopic pregnancy, salpingitis, cervical gland inflammation, that is peritonitis. In all these conditions also, these amylase levels will get elevated. That's why I have mentioned that these amylase levels are not specific. Specific means in other conditions this will not be elevated other than pancreatitis. If that occurs, then it is called specific, but it is not specific because these are other conditions. In these conditions also, these amylase levels gets elevated. That's why it is important to note that serum lipase is more sensitive and specific for pancreatitis. Other than this condition, these lipase levels may not elevate. That's why it is more specific in pancreatitis than amylase levels. So coming to the other blood test, then in blood counts at the time of admission, you can see that elevated leukocytes, that blood WBC cells gets elevated, and the liver function test may show the obstructive jaundice features, and the random blood glucose level, that because of the, as I mentioned earlier, because of the damage to the beta cells, as a result the insulin production decreases, leading to the hyperglycemia. So here see, because hypocalcemia, because of hypocalcemia, you can see the serum calcium levels get decreased, that is hypocalcemia, which suggests saponification. So coming to the now, these are the initial blood investigations what we send for the acute pancreatitis. Now coming to the imaging part. So what are the imaging modalities that are available for the diagnosis of acute pancreatitis? And to clarify the diagnosis, when the clinical picture is confusing, so because the patient may not be giving accurate history, or he may be misguided as in that cases, to determine the possible causes and to assess the severity, Balthazar score, and thus to determine the prognosis and to also to detect the complications. These imaging is useful in all these four cases. That is to clarify the diagnosis, as well as to know the etiology, as well as to assess the severity, as also to detect the complications. So what are the imaging modalities? So first, as we are very familiar with ultrasound, so we have this the initial cheapest investigation or the initial investigation, so that we can go immediately in the casualty, as well as immediately we can arrange the ultrasound. So the trans-abdominal ultrasound, it does not establish a diagnosis. So ultrasound proper should be performed within 24 hours in all patients. So don't get misguided. CT will be available, so we can go for CT. So you should not go for CT immediately, because this pancreatitis in the case of in the early stages, in the CT may not pick it up. So it takes until after 24 hours, if the pancreatitis gets evolved, then only we get a clear-cut picture in the CT. So initially we have to go for ultrasound. That also it should be performed within 24 hours in all the patients. So for what purposes? You have to know that whether the cause may be gallstones, or to rule out acute cholecystitis, and to determine the common bile duct is dilated. So to evaluate change in pancreas, that is edema, mass in pancreas. So here's what are the what we can notice in the ultrasound is, see here, transverse trans-abdominal ultrasound shows a swollen pancreatic body with ill-defined heterogeneous hypoic pattern. See, when you compare with both these areas, you can see this is the hypoechoic pattern. So this is all here we can see the head of the pancreas, this is the body, and this is the tail. So here see, you can see this area is the ill-defined hypoechoic lesion. So this suggests that this is edematous region. So and further investigation modalities is endoscopy, retroviral colonoscopy. This is both diagnostic as well as a therapeutic investigation. So to look for the gallstones. So what is the purpose of the ERCP? Is to look for the gallstones, common bile duct stones, or dilatation in patients with severe gallstone pancreatitis and signs of ongoing biliary obstruction and cholangitis. An urgent ERCP should be thought. So see, here see the normal pancreas, you can see, and here the moderate pancreatitis, that is dilated pancreatic duct, and you can see here severe pancreatitis, that is large stones in the pancreatic duct, the very dilated pancreatitis. See here, when compared to these two images, you can see the mildly dilated pancreatic ducts. Here you can see the severely major. So, and for next further investigation is plain abdominal X-ray. So plain erect abdominal and erect chest and abdominal X-ray are not diagnostic of acute pancreatitis, but are useful in differential DD. And non-specific findings in pancreatitis generalized or localized local ileus, sentinel loop, a colon cutoff sign, and a calcified gallstones. And erect chest X-ray is for any pleural effusion, that is local, any complications like pleural effusion. In severe cases, a diffuse alveolar shortening, as I mentioned that in acute ARDS, acute respiratory distress syndrome. So here see the sentinel loop sign, a focal dilated proximal jejunal loop. See here you can clearly see. This is the sentinel loop sign. A focal dilated proximal jejunal loop in the left upper quadrant, a focal area of aerodynamic ileus close to an intra-abdominal inflammatory process. The sentinel loop sign may aid in localizing the source of inflammation. is loop in upper abdomen may indicate pancreas. See, you can clearly see the sentinel loops. The colon cutoff sign and the sentinel loops are these one of the characteristic signs of acute pancreatitis. So coming to the colon cutoff sign. So you can see the colon cutoff sign describes gaseous distension seen in the upper proximal colon. See here completely. Associated with narrowing of the splenic flexure in case of acute pancreatitis. See, this is the splenic flexure. You can see the colon after the ear we can see the spleen. This is the splenic flexure. See what happens. See this hypoic region. Suddenly it's coming, getting narrower. So this is the splenic flexure. This appearance results from the inflammation process extending from pancreas into phrenic colic ligament via transverse mesocolon. This is the colon cutoff sign. So here you absolutely you can note you can see the from the hepatic flexure to the splenic flexure this colon, but here it's getting narrow. This is splenic flexure. This is called as colon cutoff sign. So coming to the CT scan, it's not necessary for all the patients as I mentioned earlier, and may reveal pseudocyst or pancreatic or abscess complication of the acute pancreatitis. A contrast enhanced CT is indicated in the following. If there is a diagnostic uncertainty in patient with severe acute pancreatitis, differentiate interstitial from necrotizing pancreatitis, and in patients with organ failure, signs of sepsis or progressive clinical deterioration. When a localized complication is suspected, that is fluid collection pseudocyst. In these cases, CT scan is useful. So see here you can see this CT showing significant swelling and inflammation of the pancreas. See, this is a hyperechoic region, this is the hypoechoic region. Around this this entire is a normal part. See here you can see ill-defined shadow. This is the entire inflammatory region. So coming to the morphological types of acute pancreatitis, the revised Atlantic, based on this revised Atlantic clarification, it is of two types, that is interstitial edematous pancreatitis and necrotizing pancreatitis. And this necrotization may occur in the parenchymal region, peripancreatic region, or as both the combined type. So first coming to the interstitial edematous pancreatitis type, this pancreatic enlargement is due to edema. So in this, you can see the edema is interstitial edematous pancreatitis because of this edema, and the pancreatic parenchyma slowly shows relatively homogeneous enhancement and peripancreatic fat stranding, and outcome symptoms usually resolve within first week. So here you can see this complete, this is all entire edema. So entire edema you can see. So and then the second type is that necrotizing pancreatitis. It constitutes about 5 to 10% of the pancreatitis cases, and the inflammation associated pancreatic parenchymal necrosis or peripancreatic necrosis cause impairment of pancreatic perfusion. Impairment develop over several days. Early CECT may underestimate extent of the disease. This slide may not be useful for you because it's PG useful for the PG postgraduate. You will not take this. So see here, an acute peripancreatic fluid collection. So what happens in this pancreatitis, in the acute pancreatitis, these are all the consequences of this pancreatitis. See, acute peripancreatic fluid collection. What happens is this peripancreatic associated with interstitial edematous pancreatitis with no necrosis. It's usually seen for first 4 weeks, and homogeneous collection of the fluid usually resolves spontaneously. When localized acute peripancreatic fluid collection persist for more than 4 weeks and develop into a pseudocyst. And second one is a pancreatic pseudocyst. As I mentioned, that is complication. These are all the complications are the consequences of pancreatitis. So encapsulated collection of fluid with a well-defined inflammatory wall, usually outside the pancreas, with minimal or no necrosis, and usually round or oval. And it appears after 4 weeks of onset of idiopathic interstitial edematous pancreatitis. Next one is the acute necrotic collection, a collection containing of both fluid and necrosis, and duration less than 4 weeks, and occurs only in setting of necrotizing pancreatitis, and singular multiple heterogeneous collection, no defined wall. And next to the final one is walled off necrosis, a mature or encapsulated collection of pancreatic, peripancreatic necrosis that has developed a well-defined inflammatory wall and appears after 4 weeks of onset of necrotizing pancreatitis. It is heterogeneous nature with liquid and non-liquid density. So here you can see the CT images of differentiating the both pseudocyst and walled off necrosis. See here, you can see the definite fluid collection in the wall. That's a wall. Here you can see wall of necrosis. There is no fluid collection. This is complete necrosed part. So this is the differentiation in brief for your understanding purpose. See all the four at one slide. The differentiating features of acute pancreatic, acute peripancreatic collection, pseudocyst, acute necrotic collections, wall of necrosis. This is very, very important slide. These are all the local complications of the pancreatitis. There is acute pancreatitis, and again as I mentioned earlier in slide, there is two types. There are idiopathic interstitial edematous pancreatitis and necrotizing pancreatitis. For the differentiating features, these are very, very important. So this is the severity scoring. How for an undergraduate level, just you remember that how will we classify the severity of the acute pancreatitis? That is Balthazar severity index. What are the criteria points we'll be taking in that is in case if it is normal pancreas, then it will be giving a points of 0. In case there is enlargement of the pancreas, then 1, peripancreatic inflammation 2, and acute peripancreatic fluid collection 3, and more than 2 acute peripancreatic fluid collections 4. So just remember this. How will you grade the severity, CT severity index in Balthazar scoring system? So coming to the assessment of severity, we can see the 3 scores, that is Ranson score, Glasgow scale, and Apache 2. These are the scores. Why this is important means because at the time of admission we will be grading the severity, because we have to assess the patient whether the patient is getting worse or this pancreatitis is getting worse or severity. If you are not able to assess the severity, then the patient may land into, as I mentioned, the systemic complications like septic shock or any ARDS or sudden collapse or any arrhythmias. The patient may develop. So for that purpose, at the time of admission, we have to score at what severity level the patient is, so that the timely intervention will be taken, so that the patient may be survived. So the scores like Ranson score, Glasgow score, Apache 2 score. So in Ranson score, what are the variables we will be taking for the consideration is to predict the severity of acute pancreatitis on admissions. Remember legal. L means leukocytes. Leukocytes should be more than 16,000, and E for enzymes, that is AST more than 250, and G glucose more than 200, and A age greater than 55, and L LDH more than 350. So among these 5 variables, based on the initially at the time of admission, we will be noting these variables. So among these 5 investigation, if the patient has any alteration in any of these two variables, if there are 3 or more factors present, so if there is leukocytes more than 16,000, or enzymes like aspartate is more than 250, age more than 50, then we will term this as severe. So 3 out of 5, if this contributing more than 3 factors among these 5, then it is the patient severe. So similarly, after 48 hours, again we have to see the score. So because to know the prognosis, whether the patient is on improving side or is getting worse. So in that case, see what are the other variables? Then calcium, hematocrit fall, partial presence of oxygen, base deficit, blood urine nitrogen, sequestration. So if this again more than 3 variables are present, then again its condition is severe condition. If there is improving pattern, then all these variables will not be seen. You will be on improving side. So very, very important. Ranson score is for the prognosis or in assessing the severity of acute pancreatitis. Very, very important. So these are not, you may not remember all these things, Glasgow scale. Just remember this Ranson score. This Ranson score is very, very important for assessing the severity and also the prognosis of the acute pancreatitis. And another is Apache score. If the score is more than 8, then it is termed as severe acute pancreatitis. So coming to the management, this is also very, very important for your essay question. It's an important essay question as well as 4 marks. How will you manage the case of pancreatitis? So again, in pancreatitis, based on the severity assessing scores, there may be mild pancreatitis or a severe pancreatitis. So in case of mild acute pancreatitis cases, you will advise nil by mouth fluid restriction, that is 4 pins, and analgesia, that is tramadol, 50 milligrams. 3 times a day, and we have to find the underlying etiology cause, that is whether it's gallstone or any inflammatory conditions or any trauma or any drugs, and there is no role of any antibiotics. So coming to the severe acute pancreatitis, how will you manage means you have to admit the case to the intensive care or high dependency units, and we have to the patient may present with dyspnea, so you have to give for oxygen supplementation. As I mentioned earlier, you will be present with severe acute pain, so you have to give analgesia. And as the patient may be because of the high grade fevers as well as the inflammatory condition, there will be dehydration. So we have to give the patient aggressive fluid therapy. Because if we fail to give these fluids, the patient may land into septic shock and suddenly hypertension may develop. So we have to monitor the signs, and we have to hematological and biochemical patterns. These hematological patterns, as I mentioned earlier, that leukocytes, leukocyte, WBC, everything we have to monitor, and biochemical parameters like amylase levels and lipase levels. And nasogastric drainage and antibiotic prophylaxis like imipenem and cefuroxime in case of severe pancreatitis, because of because in this condition there will be any superenteral infection, bacterial infections, and we have to go for CT scan, or we have to grade the severity based on CT scan, and ERCP should be done within the 72 hours. And supportive therapy for organ failure, like as I mentioned, the organ failure like it may be cardiovascular system, renal or pulmonary, or any liver, anything, and nutritional support should be given. So coming to these are one of the important part of this discussion. There's complications. What are the complications of this? Is an important viva question also. They'll be asking here, what are the complications of acute pancreatitis? Coming to the systemic complications, that is cardiovascular, shocks, arrhythmias, and in case of respiratory system involved, that is acute respiratory distress syndrome. And coming to the renal failure, how renal failure occurs in this case in pancreatic patient, because as I mentioned earlier, the inflammatory mediators release. As a result, the patient may develop go into sepsis. As a result of sepsis, there will be septic shock, and because of septic shock, there will be hyperperfusion of the kidney, and finally leading into the renal failure. And how hematologically disseminated intravascular coagulation is a complication seen in hematological parameters. And coming to gastrointestinal system, it is ileus. And metabolic, that is hypocalcemia, hyperglycemia. Why hyperglycemia? Because of the damage of the SNR cells, and also beta cells, there is a lack of insulin production, further leading to the hyperglycemia. And hyperlipidemia, saponification, neurological disturbance like visual disturbance, confusion, encephalopathy, and miscellaneous like arthralgias. So coming to the local complications, that is acute fluid collection, sterile pancreatic necrosis, infected pancreatic necrosis, pancreatic abscess, pseudocyst. And other local complications include pancreatic ascites, as I mentioned, because of the hemorrhage or any inflammatory of the body or head or tail regions are the leading to the edema. This edema further leads into pancreatic ascites. And also you can see that, as I mentioned earlier, the left-sided pleural effusion is most common case in case of acute pancreatitis. And portal or systemic vein thrombosis, pseudocyst formation. And then how will you manage? How will you manage this complication? In case of acute fluid collection, no intervention unless pressure effect is seen, pressure effect present, and aspirate under ultrasound or CT guided or trans gastric drainage under endoscopic ultrasound guidance. And pancreatic necrosis, no need of any intervention. In case of infected pancreatic necrosis, you will go for aspiration, that is aspirate under CT guidance, and percutaneous drainage. Prophylactic antibiotics should be done as we're inserting external in an oxystimulate. So if the patient deteriorates, necrosectomy, closed continuous lavage, closed drainage, open packing, closure, and re-laparotomy. And in case of pancreatic abscess, we'll go for percutaneous drainage and antibiotic coverage. In case of pancreatic ascites, again we'll drain the excess fluid and also parenteral or jejunal feeding. In case of pancreatic effusion, percutaneous drainage under CT guidance, portal or systemic vein thrombosis, aspirin in the early process. So because to prevent this complication, we'll give aspirin in the early process. In case of pseudocyst, this percutaneous transgastric cystogastrostomy, and we have to place double pigtail drain, endoscopic under endoscopic ultrasound guidance, and place the tube drain and surgical drainage, internal drainage into gastric jejunum lumen. So this is a cystogastrostomy. So this, and thank you. And this, so in this, what is to summarize this class, what is important for you people is to know the clinical features. How will you investigate this case, and how will you manage this? So simply just see these clinical features. As I mentioned, the patient will be present with upper diffuse upper abdominal pain, and is associated with nausea, vomiting. So these features you have to know. The purpose is you have to know the symptoms, how the patient present in acute pancreatitis present, and how the patients of acute appendicitis present. In case of acute appendicitis, this patient will present with right iliac fossa pain, whereas in this case, this patient may present with upper abdominal pain. So don't get confused. In appendicitis also, the patient sometimes may be present pain around the umbilicus. So in acute pancreatitis also, the patient may be presenting the pain in the upper abdominal region. So the differentiating feature is here the patient associated with nausea, vomiting, anything, and also this pain peaks for about 20 minutes. So remember these things, and in both the cases, the pain radiates to the back. So what are the differentiating features, and how will you come to the conclusion? Means on examination part, on physical examination, on palpation or inspection, you will be seeing that, as I mentioned earlier, that is great Turner sign and the Cullen sign. These are the two signs that differentiate from the acute appendicitis. So you will have to look for the great Turner sign and Cullen sign. That is bluish discoloration around the umbilicus, and also bluish discoloration around the flank region. These are the two common signs. And on investigating the patient, you will go for first initially the blood parameters like the serum amylase and lipase. As I mentioned earlier, this amylase is not so specific when compared to the lipase, but initially if the patient present to the casualty, that's initial the amylase levels gets elevated, that is more than 3 times than the normal value, that is around more than 1000 international units per ml. So in this case, so for a patient initially you have to go for serum amylase. If these levels are elevated more than 1000 levels, then after 12 hours of duration or 24 hours gap, you should go for lipase levels. If both these get elevated, then you can surely conclude that through the biochemical evidence, it may be a case of acute pancreatitis. So then you have to substantiating your diagnosis, you will go for any imaging. So initially, what imaging we will be easily available is ultrasound. So in the ultrasound, you will look for the body, head, tail, and you will see for any edematous fluid collection or something, or any gallstone obstruction. How is the bile duct, whether it is dilated or normal. So if this is not, if we don't get any conclusive evidence, then we'll go for CT scan. In the CT scan, you will be staging the what severity this pancreatitis is. Is there any calcifications? If there is any calcification, then it is not called as acute pancreatitis. If calcification occurs, means it is a long-standing condition, disease condition. So this is definitely a chronic pancreatitis. So then how will you, so some of the important signs, as I mentioned, in the sentinel loop sign, colon cutoff sign, these signs are very important because these are the bit-oriented questions, but also they will be asking in Viva. So what are the signs you will be seeing in X-ray, and what are the signs you will be seeing in a plain abdominal X-ray, and in ultrasound, what are the signs you will be seeing, and CT scan, what are the signs you will be. In case of chronic pancreatitis, you will be seeing a chain of snakes appearance, that is in chronic pancreatitis. So this is the how you will diagnose in the acute pancreatitis. And now coming to the management, as I told is, you will be, before the managing the case, you have to assess the severity. How will you assess the severity? And based on the Ranson score criteria, Glasgow scale, as well as the Apache 2 scale. Among these two, we will be using most commonly Ranson score. So the as I told you, remember that variables like legal, as I mentioned, the L for leukocytosis, E for something. So you have to initially note at the admission level, before 24 hours you have to take the variables, and after the 48 hours you would be. So in this way you will be assessing the severity. Then you will go for management. How will you manage the case, whether it's a mild case or a more severe case? In case of mild case, so just brief management, just simple management, that is will be noted. In case of severe cases, you will be going prophylactically, will be giving antibiotics, nasogastric tube drainage, and everything will be. So then we will assess the complications. What are the complications this patient is having? Then we will treat the complications. So this is how you will manage the case of acute pancreatitis. Thank you.